Hello, nurses. This is Kevin with Nursing KAMP.com, and this is my renal course on acute kidney injury post-renal conditions, where I cover the most important things about this condition and the management of it. It not only includes the video, but the study sheets found on Nursing KAMP.com. So let's get into it. Okay, we're going to talk about what you should know about renal acute kidney injury post-renal, and it's from my Nursing 7, where I cover the 7 most important things about renal failure, and we're covering this stage right here, which is called post-renal failure. And what we start off is a general study sheet where we cover all the renal conditions, and these conditions are separated into what's called PIP, P-I-P, which is basically pre-renal, before the kidney, intrarenal, inside the kidney, and then post-renal, after the kidney. So those are 3 conditions that are underlying. So when we're talking about acute kidney injury, we're basically saying this is a generic statement. Acute kidney injury, acute renal failure. They're used together as the same thing, but basically what they're saying is when you say acute kidney injury, you think what kind, because each one is going to be specific to the actions and what you need to do in order to treat that acute kidney injury. Now, all patients will go through 4 phases, and these 4 phases are basically the onset is the first phase. And when we're talking about the onset, we're talking about the actual insult. And the onset in a pre-renal condition is generally problems before the kidney. And that could be like hemorrhage, bleeding, or hypovolemia. And then what happens if they are bleeding or hypovolemic, that is called the onset. So in other words, that onset is basically just the cause. Well, with post-renal, because we're going to be talking about that today, the onset is this underlying condition. And those underlying conditions could be kidney stones, clots, cancer, or crystals, or prostate problems. Well, that's a little bit different because pre-renal is hemodynamically a process, where this is basically after the post, after the kidney. And generally, if you think of just a clot right there, there's a structural abnormality that is causing the outflow problems. So they're still going to have an oliguric stage where they're going to have no urine output, but sometimes it's just once you correct the underlying concern, they don't necessarily have to progress into the next 3 stages. So let's get into a little bit more closely and what we're talking about here. So when we're looking at post-renal failure, we're looking at after the post. And like I said before, that the kidney is basically working fine. So there's nothing really wrong with the kidney. And actually, there's nothing usually hemodynamically wrong with the patient either. So they might have a normal blood pressure or, normal volemic. So they have normal fluid volumes and everything. But like I said before, in a post-renal problem, the problem is after the kidney, and it's usually the urine outflow is having a difficulty getting out, and so the issue is that we need to treat that underlying cause. Well, the big interesting thing about labs, and when we're looking at hemodynamics, what we're really looking at is what the pathophysiology is. However, with post-renal, there's really nothing wrong hemodynamically, so labs don't necessarily will show up as a problem. So what we really have is we have to look at the structure. So we have the kidneys up here, and then basically we have the ureters, right? So the ureters, and that goes to the bladder. And then it goes down to the urethra, and in between, if they're male, they're going to have a prostate right there. And so that's just basically the flow of urine. Now, we said that the kidneys are okay. So we shouldn't see any variations right here in the BUN or creatinine, which is very significant of pre-renal. In pre-renal failure, we said that pre-renal failure is 20/1, which means that the BUN is elevated, but the creatinine is okay. So the kidney is actually working fine, because creatinine is truly about the kidney functioning, where BUN be the problem outside the kidney. Okay, so labs, however, so we do have to assess, and we have to look at, what's going on in the bladder, and those are basically an assessment that we're going to look at. And so when we're looking at that assessment, so we have to look at urine, and urine is second. So we do generally look at labs first, and urine is a result of pathophysiology as far as perfusion. And so like we said before, we said that the labs aren't necessary. However, we do see no urine output, and that's because there is a blockage, right? We said that the kidneys are functioning fine, but there's some blockage going on, like clots or cancer, and especially with like bladder cancer. Now, see, bladder cancer is an interesting thing, and we'll talk about that a little bit later, but if there's cancer in the bladder, it prevents urine from coming out, or the patient has prostate problems, and they can't pass through that prostate, and so they have no outflow of urine. So it still presents as an acute kidney injury. However, the big risk is we have to address this underlying concern. If we do not address this underlying concern, what can happen is that fluid and that urine can back up to the kidneys, and then they can become waterlogged. And that's called hydronephrosis. That means basically water on the kidneys. That will then increase the BUN and creatinine, which then we have a intrarenal problem. And intrarenal is a big issue, because intrarenal means that they progress to the state that they're no longer having just a blockage. They've actually affected the kidneys, and now we have a problem. So as we move on, we look at the underlying causes of acute kidney injury post-renal. In this, we're looking at the underlying causes, and the major issue right here is outflow. And like we said before, that if a person has kidneys and the kidneys are working, but they have kidney stones, there's an actual blockage right there. Now, the good thing, you have two kidneys, so you might not have stones, on both sides. However, it's going to go down to the bladder. And once it empties into the bladder, that stone might pass to the bladder. And then what happens is that we have no outflow. And when we have no outflow, we need to worry. We worry about it, because the fact is that the person doesn't have any urinary output. Now, if they're presented with a kidney stone, we know there's a problem, because generally with kidney stones, there's major pain, flank pain. And so, but as that kidney stone starts to pass, it can get lodged in the bladder, or in the ureters, or on the prostate and the urethra, and actually cause a blockage. And then that, once again, the urine is still working. The kidneys are still working and pouring out urine. But if there's a blockage, it starts to build up, and once again, the risk is hydronephrosis. So when we're looking at the next thing, we're looking at like prostate problems. Well, prostate problems are a little bit different, because the location is different. Well, first of all, females don't have prostate, so therefore they don't have that problem. However, males do have the prostate, and as they start to age, that becomes more difficult. So what happens basically is that if there's prostate cancer, for example, you actually have a pressure on the ureter. So then the kidneys are still working, so you have a normal BUN and creatinine, because the kidneys are producing urine, but they're getting blocked by that prostate. So what do we do for this? Well, we need to assess, and that's one of the big things. And we have to assess this bladder, and we have to see whether or not there's actually fluid in there, and there's actually urine. So what we do is we do a bladder scan. And that bladder scan is basically an ultrasound machine that will basically scan the bladder and check for residual. Now, I generally will think of a bladder scan. You take a B, right? You look like that, right? You take this 1 down, right? So that's 100, and then that B becomes 300. So you have two measurements. You have 100 or 300, and that's generally the range of urine that should be in the bladder. Now, if they've just voided and there's less than 100, you're okay. So there's nothing wrong. However, if you have greater than 300 or 250 and above, you generally will need an intervention, like put a Foley in or something like that. You need to do something about that, because that's too much urine to be in the bladder, and that means they're filling up. And like I said before, the risk is that it becomes hydronephrosis. So we basically would do a bladder scan, and we were going to assess how much fluid they actually have in their bladder. Now, if they have a lot of fluid in there and they have a history of BPH, then we can think most likely that this is a post-renal concern, because the prostate is actually blocking that urine outflow. So, what do? We put a Foley in that person, and we keep them on medications like alpha-2, like tamsulosin, or any kind of alpha-2 medications that will work specifically on the prostate. The next thing is cancer. Now, cancer is specific because cancer could happen in the prostate, and it can also happen in the bladder. And if you're a smoker, please stop. And you're smoking a cigarette, well, the big issue with smoking is that it will basically go into the lungs. And once it goes into the lungs, it's going to go to the alveoli. And once it goes into the alveoli, the smoke comes in here and it goes into the bloodstream. Well, the interesting thing about the bloodstream is it has to go to the kidneys. And once it goes to the kidneys, it goes into the urine. And then once it goes into the urine, it sits in the bladder. So that nicotine needs to get out of the body. Well, people who have urinary, where they hold their urine for long times and different things like that, like truck drivers. If you think about a truck driver who's driving a truck for long distances and he's taking a couple exits a little bit more and not urinating, meanwhile he's smoking, what happens is this nicotine starts to form here, and they actually get bladder cancer. So the number one cause of bladder cancer is actually smoking. So if a person has cancer, the issue is that you can have problems that the cancer could be in the prostate or it could be in the bladder. Well, I mean, you need to treat the underlying cause of that in order to treat that. Another thing, too, that we have is another cause, which is clots. And, clots are generally from, like, if you have a cystoscopy, right? So if you have a penis and you are going in and you're doing some sort of treatment, a cystoscope, where you're taking a look up there and seeing what's going on, and what happens is that you could have bleeding. And that bleeding could become clots. And the problem with those clots is because that can become post-renal failure, once again, an outflow problem. So if you generally think that, something's blocking the flow, but the kidneys are working fine. And that's the big key about this, is that post-renal is a little bit more treatable, in the sense that we just try to recognize that there might be a problem. So, like, if, for example, if a person has a TURP, for example, and they remove this prostate, well, we do continuous bladder irrigation, where we put up an IV and we basically IV bag, and then we basically will continuously flush that area, because the risk is we don't want to have, because we just took out their prostate, we don't want that person to have clots. Because if they have clots, they could have post-renal failure, and then that becomes a big issue. The last thing we're going to talk about is crystals. And crystals are, uric acid, nephropathy, where they basically build up, and a lot of times with severe hydration. Some sulfonamides, cyclophir, cause this blockage, and these uric acid crystals actually just start to build up, and next thing you know, we start to have renal problems and outflow problems. So we watch those medications and make sure that we're monitoring them whenever they're getting these things. The next thing we're going to do is that, so what are some of the nursing interventions that we'll do with the patient with post-renal failure? Well, there are some basic things that we're going to do. We're going to anticipate a bladder scan. We're going to bladder scan them. We're going to look for any range from between, we said that B, that 100 to 300. And if it's greater than 250 to 300, we're going to do a intervention. Now, if they're in between 1 and 300, follow your policy. We might also start to, we might do a Foley, right? So we might try to pass a Foley, because if we think there's a problem, we're going to try to see if that will correct it and see if we get some outflow. Sometimes we even might give Lasix. And the reason we give Lasix is that if we're unsure, we don't know what's going on, sometimes we'll give them a little gentle Lasix just to see if maybe that might be the problem. So we don't exclude it if we don't know what's really going on. Ultimately, we can do, in the end, we'll check a renal ultrasound. Then the reason we do a renal ultrasound is because of if the patient has a post-renal problem that has developed, we want to look at this for hydronephrosis to make sure that there's no fluid on those kidneys. Because if they get hydronephrosis, they're going to have an elevated BUN and creatinine, which now means that they're going into a intrarenal problem. Okay, so when we're looking at this in post-renal failure, the big issue with post-renal failure is not necessarily the labs right away. The labs become an issue when it becomes to pinning. So which I mean is that pre-renal can become intrarenal, so they can pin to this side. And post-renal can become intrarenal, which means it can post to this side. So any post-renal problem, like kidney stones, prostate cancer, clots, or crystals, if you don't address it and deal with that situation, it can become intrarenal. And how do we know it? Well, this BUN and creatinine actually begins to be elevated. So, we do a lot of assessment prior to that, but once they have an elevation of BUN and creatinine, that's a doctor's call, and we're going to call the doctor and tell them that this is actually changed from what was going on before. But a lot of times post-renal failure, we try to treat the underlying cause with either BPH meds, Lasix, or continuous assessments of bladder scans. All right, let's pull it all together with post-renal, and let's look at it. Now, a person who can be walking around and suddenly get post-renal, if they have a history of BPH or have a history of cancer or clotting things, they could be going to the doctor because they're noticing some hesitancy in their urination and some problems, and that is a precursor to actual post-renal problems. They could actually come in by ambulance because they can't urinate, and that's a big issue. They could be sitting in the office. This happens a little bit more with males, and actually as the ages go up, with BPH mainly. However, with the other conditions, anybody can get a kidney stone, and anybody can have clots or cancer and the other things. Symptoms 3. Well, these are 3 things that are most likely with post-renal. A urinary output, there's nothing. There's no urinary output, but you have normal BUN and creatinine. Also, symptoms is a sense of urgency. They feel like they have to urinate, but they can't urinate. And also, symptoms would be, could be clots, it could be devices, post-surgical, post-cystoscopies, or something that has resulted in it. Precipitating factors are generally history and post-renal. The big main complication is that this patient becomes intrarenal, and the way they become intrarenal is from the BUN and creatinine being elevated. And we would call the doctor. This is the acute 3, the 3 things that you would call the doctor for. If you bladder scan somebody who is greater than 300, you call the doctor to figure out what you need to do, because an intervention needs to happen. That's too much urine to be in that person. Sometimes even 250 is too much. If you have no urinary output and the BUN and creatinine is normal, and there's a post-renal potential, it could be acute kidney injury, you call the doctor. And also, if the person has post-renal failure and they suddenly had a BUN and creatinine being elevated, that has become an intrarenal problem. So will they be on a monitor? Not necessarily. These patients could be on med-surg. Blood pressure is not really hemodynamic status, no lung sounds or anything like that. Lab work, well, labs are going to basically look benign. They're not really going to be affected, maybe on a differential, but not really. So labs are inconsequential because it is a structural abnormality and there's a blockage. Hands-on positioning, whatever the patient wants to be in, diagnostics, ultrasounds, the kidneys, and also bladder scanning. IV fluids, no, because they can't output, and Lasix sometimes just to evaluate. Temperature, not really. Pulse, increased because of pain. Respirations, no blood pressure issues. Pulse X map. Fluid statuses, they're filled and they can't quite urinate, and that's the issue. Pulses should be regular. No real mentation other than anxiety. Nothing with the heart, nothing with the lungs. It's all kidney and outflow. So it is all down here, and it's episodic. Once it's resolved, the patient can generally go home, be discharged. Generally, they might be admitted on a med-surg floor, sometimes ICU, depending, and they might go to surgery if there's a major blockage. Well, that's it. My name's Kevin, and this is Nursing Camp, and this was my post-renal lecture. Please see my other lectures where I cover intrarenal, pre-renal, and general overview of acute kidney injury. Thank you. Follow me on nursingkamp.com, and we'll see you next time.